My name is Jonathan Lever with Better Health Partnership, and Jen Kons with United Way, and we're going to tell you about some of the work, the exciting work that we've been doing over the past months and over a year, actually.
Do you want me to click?
That's okay.
Okay.
So the title of our presentation here is New Efforts in Social Determinants of Health and Why Now? So there's been a lot of increased emphasis on social determinants, as we've heard today. There's high rates of infant mortality, which Kirsten and Greg and Heidi illustrated with the new 2018 assessment. New data on pediatric asthma disparities, that was one of the priority areas, and actually this is just some data that Better Health Partnership has collected from the local health systems that contribute data on asthma rates, and you can see on the right-hand side the disparities that exist across different subgroups. Black or African Americans alone are about 7 times more than folks with high income or whites. And on the left side, you see a map of all those little blue dots are kids with an asthma diagnosis, and the yellow dots are kids with an asthma exacerbation. So that would be either a inpatient stay, ED visit, observation, ICU stay. The green outline is the city of Cleveland, and the red outline are target neighborhoods that we're looking to with an intervention that we'll tell you a little bit more about. One more just sort of data slide. You can see that when we group the data by groups, so that when we combine low income, African American, Medicaid, non-Hispanic, you can see that there's almost a 9% higher chance from high income white populations. So you can kind of see these stark disparities that the assessment that came out today has utilized. So getting back to why now, right? So there's a lot of these social inequalities. There's a lot of growing interest from Medicare, Medicaid services to really sort of attack these social determinants in a sustainable, organized fashion. So the goals of the work that we've been doing are to develop some long-term sustainable ways, systemic ways of addressing these social determinants, and see what sort of policy and financing options exist to address these social determinants. So the first project that I'll speak about is what we call the ClinictoCommunity Linkage project. Really, healthcare providers have great intentions to help patients, but they're largely unequipped and under-resourced to do that right now. There's a great divide between social service and healthcare. We've talked to one of the local FQHCs that says we refer patients and we don't often know what happens when they get referred, right? So they're siloed in their health systems and their electronic records. And so we're trying to do things to address some of that. So ClinictoCommunity Linkage is a strategy that's supported by the CDC. It's essentially linking clinical care and community resources to better health. It was a big focus of the last REACH grant, and as you heard from Greg and others, it's a focus of the current REACH grant. So what we're doing is developing a sustainable method for linking clinical care and social services, one that's sustainable and scalable, because we know that there's a lot of need out there. And so what we're doing is we're working with, we've started with adults with hypertension, and we're going to be soon targeting children with asthma or obesity. You saw the data that shows that there's a need. And we're working with 3 healthcare systems, so Metro Health, Jay Glenn Clinic, and the Buckeye Clinic, as well as the new UH Rainbow Center for Women's and Children, and Carolines in the central neighborhood. The targeted neighborhoods you see are up there, and those were those neighborhoods in the red outlines. So what we're trying to do is develop a way, basically interoperability between healthcare and social service. So essentially, in the model that we've launched at Jay Glenn, patient comes in, if their blood pressure is elevated, there's an electronic mechanism that pops up and alerts the MA in this case, or the nurse, that the patient's blood pressure is then elevated and they might be eligible for this program. They'll explain the program to the patient. There's a brochure I'll show you in a minute that they get. And then they can seamlessly make an electronic referral. It's secure, and it travels directly into the United Way system. And they can then open up that record, and there's a dedicated navigator. There's a 211 navigator that's dedicated to this program. They will be tied to that, so it's a little bit different from the regular 211 services that people call. This person is specially trained to do the navigation, and they are following up with this patient. So they will call the patient, they will assess the patient, what are their needs, we'll have a conversation around healthy eating, active living, chronic disease self-management, as well as other needs that the patient may have, transportation, utility, housing, etc. They will find resources for the patient and then help them get that patient connected to those community resources. At a later point, whether it's a week, a couple weeks later, they'll call back the patient, see how the patient is doing. If the patient's resources met the needs, great. If not, they'll actually go out and find more resources. And so that's the community resources are those blue boxes. And then that information will be sent back to the healthcare system so that there's that closed loop. So no longer are the health systems saying, well, we referred people, but we don't know what happened to them. Okay, so they'll actually be getting that information back into the EHR. What we've done so far, this is the brochure that the patients will receive, that they're actually receiving as part of the hypertension work. This is an example of the pop-up that appears. So we've taken advantage of the technology so that if the patient's blood pressure is elevated, there's actually a second pop-up that appears to tell the provider to retake the blood pressure. But if on that second repeat blood pressure it's still elevated, this pop-up appears, they get patient consent, and once they click the order button, it's sent electronically. So there's no faxes, there's no paper, it goes directly in a secure HIPAA fashion, and we won't get into all the technical details of how that all happens, but it happens, and then 211 picks that up and then goes from there. What we're looking at in terms of outcomes are mainly related to health outcomes, referral data that we get from 211, patient-provider experience with the work. How are they seeing this? So far, with what we've launched, there's been 34 patients who've opted in for this. It's only been going for about 6 weeks or so. And you know, so that's great. We actually are just getting some preliminary data from 211 around what kind of needs were found, what kind of resources patients were referred to, and we hope that some of the work that we're doing will inform some of the larger work that Jen's going to tell you about with the Accountable Health Community and the Advisory Board. And what we're really trying to do is create a culture change, right? So where providers and clinical folks really have the tools and the resources to implement and refer patients who are at need. Of course, this is just one of many approaches happening now in our county to improve social determinants of health. Where we're at for the rest of 2018, 2019, we're in the process of building the pediatric referrals. So we're working with the 3 health systems. We've actually also electronically connected UH, so they are actually electronically connected to United Way, and we've done testing, and that's going very well. We're going to be working to design workflows at the 3 pediatric clinics. Actually, later this afternoon, our team is going to be headed to UH to be working with those folks. And we're also in the process of designing an evaluation that will be meaningful for informing United Way's work, the health clinics' work, and the larger system in general. So I'll hand it over to Jen.
All right, thanks. Great, thanks everybody. So I'm Jen Kons again. I'm from United Way of Greater Cleveland, and we have kind of this parallel project, Accountable Health Communities. And Jonathan and I spend a lot of time together, learning from each other's projects, sharing resources, sharing information. So these projects are definitely in collaboration and coordination and not in competition with one another. So Accountable Health Communities, it's an innovation project funded by the Centers for Medicare and Medicaid Services. We are one of 31 localities across the country that is doing a project like this. So the goal of the project, or one of the main components, is to systematically screen for and identify social determinants of health. Our hope is that by screening for patients' social service needs and linking them to services, that we can impact cost utilization, so reduce unnecessary emergency department visits, and improve health outcomes. We have about 3.5 years left to fully implement the project and see if we can make a dent on some of these issues. Our goal each year is to offer the screening to 75,000 people in our region. And then of those 75,000 people, about 3,000 of them would get navigation or ongoing assistance with navigating the social service system and meeting some of their social service needs. So if we were awarded this funding in May of last year. We spent a lot of time planning and piloting the project, and then we'll be starting full implementation really in the next few weeks. So the locations that we're not everywhere. At the clinic, we're at South Point Hospital in their emergency department. At Metro's main campus, we're in 3 places: their internal medicine department, one of their primary care practices, heart and vascular or cardiology, and their postpartum labor and delivery unit. And then we're also with Sisters of Charity at St. Vincent in their inpatient psychiatric unit. So a little bit about how this works. First, when patients enter the clinic, it's a little bit easier to talk about in the outpatient setting. They come in, they register for their visit, they check in, and patients who are eligible are given a brochure about the program and asked by registration if they'd like to participate or not. So I should say that eligibility to participate is based on a couple things. One, you have to be, because it's funded by Medicare and Medicaid, you have to be insured by Medicare or Medicaid, and that does include all the managed care plans. And you have to live in the cities of Cleveland, East Cleveland, or Warrensville Heights, although I think we're going to be expanding some of that geographic area soon. So if the patient says, yes, I'd like to do this, it gets marked in the record, they opt in, and then they complete a screening tool. So there's 14 questions. The tool was designed by CMS. They're validated questions. There are things that we like about this tool and things that we don't, but it does screen for 5 domains of social determinants of health, and I'll get into what those are. Based on the results of that screening tool and how patients answer, 211 uses its resource database to identify referrals that might be appropriate for those needs. And so we make sure that before patients leave that they get a copy of those resources. So everything kind of happens in that one visit. And then also while they're on their way exiting their visit is when we'd also talk to them about navigation. So for those patients who identify a need and have told us that they've had 2 or more emergency department visits in the last year, we would offer them that ongoing assistance and navigation of the safety net. It's up to them if they want to participate. A lot of folks do. Some folks say, I have enough case managers, I don't need another one, which is perfectly acceptable. And then if they do choose to opt in, then we follow them. We work with them for a year. So a little bit about our screening tool. Like I said, it's 14 questions. The domains that it asks about are living situation or housing, food security, transportation, utilities, and personal safety. There are options for additional questions, additional domains. We chose to start with these 5, but we could add questions on employment or economic stability, domestic violence, mental health, and we may choose to do that in the future. It also asks some demographic questions around income, education, and race and ethnicity. And I should note, it's a survey designed by the federal government, so it uses the federal definitions around race and ethnicity. It also asks about risk level, or how they define risk according to emergency department visits. A big difference between this intervention and the work that Better Health Partnership is leading on ClinictoCommunity Linkage is this isn't really driven by a health condition or a diagnosis. It's not driven by acuity of a health outcome. It's really meant to be broader than that and not disease specific. Although there is the practices we're at do have prevalences of some diseases, but the referral isn't driven by that. So we've been piloting for a few months. Most of our volume right now is at Metro. So a little bit about what we found to date. So this is about 500 and some screenings that happened between late July and late October. Of those screenings, the biggest need that folks identified was food. So the first worried that food would run out, or that food actually did run out. The food they bought didn't last through the month. So the question asked about in the past year, have you worried you'd run out of food, or have you run out of food? So those are both above 65% of respondents are saying yes to that. The next is living situation, which is not so much about housing stability, but about housing conditions, right? So do you have mold? Do you have leaky pipes? Do you have working fire or smoke detectors? So a little under half of respondents, 44%, identify that as a need. Next, transportation, utilities. So utilities have been shut off or threatened to be shut off. Then we get to housing stability, that you don't have a stable place to live, or you're worried about losing your housing. And then we end with, there's 4 safety questions that kind of start with physical violence and end with emotional and psychological abuse. Well, actually, they're the reverse. So of all the patients who have responded so far, only 8% have identified no needs, right? None of these things apply to them. So we know that we have a high degree of need in our community, which we kind of knew anyways. But the cool thing about this, one of the cool things about this project, is that we don't have a great repository of how needs intersect, and specifically how they intersect with the Medicaid population. So before we even start to figure out what to do about this, just knowing kind of where the biggest vulnerabilities are is, for me, a big step forward. So the next step is, so we identify the needs, and then we try to link people to services. But we also do some work on measuring kind of, well, where does our safety net system fall short? Where are we not able to meet community needs? And I think a lot of us in this room could probably identify, there's not enough affordable housing, transportation isn't always sufficient. But again, we don't have a lot of strong documentation on that. One, how those needs intersect, and the volume to which needs remain unmet in our community. So one of the things that we have to do, and that we want to do, is pull together an advisory board of individuals across our community to try to start to identify the gaps in our social service delivery system. So what are we able to do, and what are we really not doing well enough to address social determinants of health? The advisory board also looks at the equity of the intervention. Are we really serving the people who need the most? Is it falling along the racial and economic portfolio of individuals in the Medicaid population? And then once we've addressed the gaps in our social service delivery system, what are we going to do about it? So where can we start to make some inroads to better align the services that we do have in our community, or bring more resources in to create new opportunities for folks? So a little bit about who's on the advisory board. It's our clinical partners. It's social service providers, so human service providers. To me, that's a big deal that those folks are at the table. I think a lot of us in this room come from a healthcare or public health perspective. We're not always talking with the folks who are actually providing housing and food and transportation. And if we want to impact those areas, then we have to be at the same table, right? And we have to respect that our priority isn't necessarily their priority, right? Yes, they're concerned about the health and well-being of their clients and the communities they serve, but it's not paramount, right? They're first concerned about the housing stability of their clients, or they're first concerned about the food stability of their clients, and they're not always thinking about it through a health lens in the way that we are. We also have the Department of Medicaid at the table, as well as the managed care plans for both Medicaid and Medicare, and the dual eligibles. Researchers from our local universities, some government folks, so folks from the city and the county level, foundations who can help us figure out how we can bring more resources into the community, advocates, and then I think most importantly, having beneficiaries at the table, having people who participate in these programs, who are insured by Medicare or Medicaid, who need to navigate the social service delivery system and the healthcare delivery system, having their voice represented at the table. So that's most of us. So 2 kind of big projects that the advisory board does. First, every year we create this gap analysis, right? So we document and identify the needs, which is a little bit of what I've been talking about. And then we create this quality improvement plan. What are we going to do about it? So that quality improvement plan can be a set of policy recommendations or priorities that we pursue together. It can be new funding mechanisms. It can be a realignment of services or a realignment of community dollars. It's really up to us what we want to do and what we think is feasible, what we think we can accomplish, and probably identifying some things that we can, some early wins that we can make to build momentum to keep moving forward with this. So that is a work in progress. The advisory board has some subcommittees on it, really one main subcommittee at this point, which is the subcommittee that develops that gap analysis and the QI plan, and that we're led by Terry Allen, so we have some great minds around the table on that. And they are really tasked with, because the advisory board is pretty big, there's like 60-some people on it, which is a lot of people to create a couple documents. So we have this smaller subcommittee that really digs deep into the work and makes some recommendations to the bigger advisory board on how we do this. Yep. So a little bit kind of about the big picture of where we think we can go. So there's various models of integration for integrating these health and human service delivery systems. At a minimum, at one end of the spectrum, we can screen and refer, right, which is where we're starting, at least with the 75,000 annually. At the other end of the spectrum, we could have pooled health and social service budgets, and I think we're a long way from there. But there are lots of places we can be in the middle. We could be offering social services through healthcare providers. We could have co-location of services. We could have more partnerships and collaboration. And a lot of the work of the advisory board is to figure out, how can we move along this continuum and where can we have some impact. So in summary, both of these projects, CCL and AHC, are trying to find efficient ways to identify needs and provide resources to patients, right, to bring together these health and human service sectors. To do that, we have to have improved collaboration between the two sectors. And our overall goal is to reduce these system costs and improving health outcomes and quality of life. So we're hoping for we're working towards some big systems change, trying to do that through these smaller scale pilots and then bringing the right folks together to that can help move some of these things on a bigger scale. So that's us. There's our, what do we call that?
Funding attribution.
Funding attribution. There's our funding attribution. Any questions? Nothing. Well, we are last. Yeah. Thank you. Did you have a question?
Oh, no, by all means.
Please, yeah.
If you do save money, who gets it?
That depends on the model, right? On how we design a system. It depends, right? So it could be the hospitals that get the money. It could be the payers that get the money.
I guess I'm asking, did you negotiate in advance what would happen with the savings?
We did not. Yeah. So, I think initially Medicare and Medicaid would save the money, but I think we're looking at different payment structures that would bring more money into the system that could ultimately save more money in the system, and then figuring out who takes on the risk and who takes on the reward for that. So as I'm sure you know, there's lots of models out there.
Yeah.
Yeah, Terry.
Jonathan, a question about the asthma component in the CCL project. Does it involve educational material about triggers in the home environment, guidance for safe ways to address it, sort of self-help things, or what are the?
Yeah, so we're working with United Way with the resources that are in their database. There are some around education and mitigation of different asthma factors. So, yeah, and we're constantly building that. You know, as we learn about different programs, one of the nice things is we've actually helped to add some resources to the 2-in-1 database. So, yeah.
All right.
Okay.
Okay. Thank you.
Mm-hmm.